everyone and welcome to Rad Chat. My name's Jo McNamara and I'm joined by fellow host Number John Canderson.
Hi everyone.
Here we are live at UKIO in the pod box and we're joined by the amazing Jacob, who was one of my students not that long ago.
A decade.
Yeah, let's not highlight that.
Well, just on the podcast.
Yeah, absolutely. Let's start again. But Jacob, would you like to introduce yourself, please?
Yep, so my name's Jacob Curran. I am now a clinical application specialist for Vision RT, but I was, as Joe said, a student with you quite a while ago, and a radiographer based in Lincoln County Hospital, where I dabbled in many things, but mainly surface-guided radiotherapy, which I guess is what you guys are going to ask me about.
Maybe.
I suppose first, why did you want to go into therapeutic radiography?
That's an interesting story in itself. So it's probably a story you've heard 1,000 times. I applied to be a diagnostic, and I got all the way through.
You were too good for them.
Well, that's it. Yeah, as soon as a therapy rad saw me, they were like, "I'm having him." No, I went through all the gubbins of being a diagnostic, and then went for a site visit, and was bored for a week. Really bored. And then visited a radiotherapy department for half a day, and the interactions that the staff had with the patients, the fact that all the patients were smiling and knew the staff, and the fact I was still working with really cool, technology, which was, I'm a geek, so that was my thing. I was just sold on radiotherapy straight away, and that was Clatterbridge I visited, so I'm back in my old stomping ground. It's nice.
Oh, amazing. And so you kind of say you dabbled with SGRT at Lincoln. I wouldn't necessarily say you dabbled. They're one of the leading departments in using surface guided.
They are.
Tell us about that. How do you, as a treatment radiographer, go from implementing a new bit of kit, but then actually taking it to a point where, when you left and currently now they're using SGRT for head and neck cancer patients?
Yeah, well, it's going to vary so much, and this is what I'm learning in this new job, is the size of the centre, the variety of kit you've got, that has a huge impact on how implementation's going to go. But I think for me, working in Lincoln, it was hard at first. So I was early in my career when we first started using SGRT. Like how most centres start with SGRT, we started with the breast patients, and we had the overlap with the tattoos, and then eventually went to tattooless for the breasts. And when you do breast, it's quite easy to move to thorax, and then you start to expand out more. But in Lincoln we stagnated at breast and thorax for quite a long time. Yeah. And I think what motivated me as a young radiographer was looking and seeing we've got this wonderful technology that we could use for everyone, and underutilising it. So as soon as I sort of earned my stripes, my big thing was to up the utilisation of SGRT. And I think the best way to do it is to communicate with all the staff around you, make sure everyone's on board, and figure out who your assets are and who the people are that don't really want to change practice.
Yeah.
And the only way that happened was through speaking to people and showing people what can be done. So I started engaging with conferences and bringing back what I was learning from the conferences to the department, doing presentations. I was never one for public speaking and doing presentations.
And look at you now.
I know, push myself out of my comfort zone to benefit the department and the patients. So it really was just opening up that dialogue and saying, we've got this, here's what they're doing in XYZ place, why can't we do the same here? And as I alluded to earlier when I talked about how it's going to vary from department to department with what kit you've got, how many different machines. I've always said to people I was very fortuitous at Lincoln. We had 3 of the exact same linear accelerator, all with the same SGRT system. So although yes, we achieved a lot, me training everyone and getting everyone to that point was quite easy.
Yeah.
But yeah, I think it's just, you've got to open up that dialogue, you've got to speak to people, and really sell it as something for the patients. It is a big change for people.
Yeah.
But the thing is with SGRT, tattoos are 3 tiny little points, or 3 to 5 small little points. And the SGRT, you're looking at the whole surface. You can look outside of the area that you're treating. You can look at parts of the body that you wouldn't even normally think this is going to have an impact on my setup. And once you get the radiographers thinking like that, it all starts to fall into place, and it becomes a tool not just for setup, it becomes a tool for problem solving. It's the first thing I would turn to when a complex patient turned up. And yeah, it was really, I mean, they're a great team in Lincoln, and I was, again, really fortuitous that they were so engaged and willing to try. But it's just been a huge culture shift. Like, they can't, if you go to speak to the students at Lincoln now, they can't perceive any other way of setting patients up, which is wonderful. Because I strongly believe it's better for everyone involved.
But what happens if they move to a department that doesn't have SGRT then?
It's a fantastic question. So that happened. Obviously, we tried to have our electives, and I think they've got a wonderful practice education team in Lincoln, and I think that they're trying to send them to departments that still use tattoos because they need to get that experience.
And we do a lot of simulation, and I think a lot of HEIs utilise simulation. So, and if you're able to learn with both, then wherever you go, hopefully you'll be able to adopt whatever method it is that they're utilising.
And I would hope that at some point, sometime in the next decade, there will be no more tattoos anywhere. We'll see. That's my goal. That's why I've joined the company that I'm in now. That's what I want to see. So I made it happen at Lincoln with my 3 Linacs. So only how many Linacs are there in the UK?
Oh gosh, I don't know how many Linacs there are, but only 70 plus departments. So
only a few hundred more Linacs to go then. It's fine. You can do that. But no. What was the question again?
No, you answered it.
I answered it. Oh, students with tattoos. Yeah. No. Like you say, it's great for them to learn both. I think learning surface guidance as a student is really important. I'm really interested to see what the next generation of radiographers are going to be like, and their knowledge of how surface anatomy relates to internal. Because even I learned on tattoos. I've had to learn that later on in life, how what I'm doing to the surface affects the internal anatomy. I think we're going to have a really strong workforce in the future that understands how, if I manipulate the arm in this way, if I manipulate the chest in this way, they're not only thinking about what it's doing to the surface, they can start to piece together what it's doing inside. And I think that's the next step, and we'll see that in the young next generation of radiographers.
I think that will help with talking about side effects and late effects as well. If they know what's happening where, hopefully then, being able to just tell the patient, well, on your body this is what's happening, that's kind of what we want. I don't think you see it enough sometimes, but that's also probably a bit of confidence that as a student you wouldn't talk to patients about side effects, but actually you'll be listening to the other radiographers around you, and obviously that's how you learn and grow. Yeah,
definitely. So, and some of the things that SGRT is doing now, it does come back to the side effects and everything. It's we're looking at ways that we can make non-coplanar treatments more accessible and things like that. So it all ties back in together, and I think part of the student pathway is that eureka moment where everything kind of falls into place, and you go, oh, that's why I do this, because it has an impact on this, and it's great. It's great.
And how's it been transitioning from clinical into then industry?
I'm only 2 months in, so I'm still learning the ropes, but it's very different. It's a very, very different world. Obviously, for the last sort of 4 years or so, I've been doing all the conferences and everything, so there's a lot of familiar faces here, such as yourselves. But it's very different. I thought I'd miss the patient contact, and in a way I do, but I'm still in centres where I see the radiographers interacting with the patients. I still have some small interactions with the patients, and it's almost like every new centre I visit, I get that feeling I had sort of 10 years ago when I first went to Clatterbridge, and it's like, I remember why I'm doing this now. Because I love Lincoln to bits, and it will always be my favourite little centre, but you spend too long somewhere and it does just sort of become repetitive, and you lose that magic, whereas stepping out into this, I feel I've got my mojo back a little bit.
Amazing.
Thanks very much.
All right. Is that it?
That's absolutely
Is that podcast done?
Yeah, well done.
Was I all right?
Yeah, thank you so much.